going to get all 4 of you. I had to do it in landscape the other day and it puts it sideways when I upload it. So, I wonder if I put it up here. Whether it will work. Like that. I'm going to sit on some lungs.
I don't think I was going to stay there.
Yeah, well, come
Oh, 1 minute.
Yeah.
Literally.
on. You can't see my slides, but it doesn't matter. Is that all right? Do you mind being on camera? I don't. It won't know what you're looking at though. I'll just edit that bit out. All right.
Does it need to know what we're looking at?
You just have to have 4 people in here. I need to be talking to you about behaviours of concern. Have you all got this?
Yeah.
So it's all come up? Is it this or that? I don't know. I need a mouse, really. So, first of all, welcome to country. I'd like to acknowledge the traditional owners of the land on which we are gathered and pay my respects to their elders, both past and present. We're talking about behaviours of concern. I have to be able to see. So, where are you all? Do you want to come in closer so you can see if I turn it to you?
Will that? Yeah. Will probably then not be in the screen. I can see it anyway.
Yeah, we've got
Alright,
it.
so
on phones.
Yeah, we've got it here.
So a couple of interactions now with our new learning techniques. They don't want us to just talk at you the whole time, which is good. It saves me. So we have to give you little questions and quizzes and things. So can you answer this question? Which behaviour would be a behaviour of concern? Aggression, intoxication, intrusiveness, violence, or all of the above? Very good. Maybe you can help me petition for a monitor, so I don't have to do this. Aggression, confusion, or other cognitive impairment or intoxication. That's what we're going to talk about in the first session. So aggression, actions or behaviours aimed at causing harm or damage to people, animals, or property. I actually have a video for you guys, just in case you don't understand what aggression is. And we will turn it a little bit so I can see. I'm assuming you've all dealt with somebody who's been aggressive.
Aggression is physical or verbal abuse directed towards a person or towards an object. What you might see with physical aggression is someone hitting out or slapping or kicking or biting, even pinching. With verbal aggression, it's shouting, it's intimidation, that sort of loud voice. Aggression can be relatively mild, where someone is a bit upset, a bit grumpy, and they shout back or they push someone away. Or it can become quite significant, where someone is clearly very angry and becomes almost uncontrolled in their pushing away or their hitting or their screaming and yelling. There's a number of reasons why someone might become aggressive. They can simply be unhappy with the situation. Perhaps their family member or the carer has upset them. It might be the environment that they're bored, or perhaps they're scared. It can be an illness, a physical illness, it can be pain. There's a lot of reasons why people can become upset and aggressive.
At Dementia Support Australia, we help you understand the changes in behaviour that may be impacted by things such as pain.
She says that every time, so we'll get to hear her say that a few times. Okay, so I want us to demonstrate our understanding of aggression. Everyone has to, let's pretend we don't know each other's names. You just do it. and say your name in an aggressive way. Starting with you because you're so aggressive.
My name. Talia. It's like, yeah, so aggressive. So aggressive. Emma.
Hello, Emma.
And Kaz.
God, simmer down, will you?
Chantal.
Okay. So we all understand aggression?
Yeah.
Have we been faced with aggressive patients in the past? Yeah. As students? As new grads? Yeah. It's not fun. Okay. So each learner needs to demonstrate a behaviour of concern as they understand it, but we'll get through this first and then we'll demonstrate some of these behaviours. So aggression, actions or behaviours aimed at causing harm or damage to people, animals or property. I'm pretty annoyed about the animals one. This is so awkward. Sorry guys. It can manifest in various forms, including physical aggression, hitting, biting, kicking, verbal aggression, shouting, making threats, name calling and other harmful behaviours. No. Open to suggestions to make this an easier thing to do, by the way.
Does the space bar work for you?
No.
Or the arrows.
It doesn't. This is Mentimeter, it's not PowerPoint. So aggressive behaviour is concerning because it can lead to physical injuries, psychological harm and social consequences. It can disrupt relationships, create an atmosphere of fear and even have legal implications. So there's all different types of aggression obviously. Physical aggression, we've just talked about. Hitting, biting, kicking, scratching, punching, you get the gist. Verbal aggression, it's probably what you're most often going to face as a nurse. Verbal aggression towards others, which can include shouting, making threats or calling names. Self-injury is also a form of aggression. Actions where an individual causes harm to themselves, such as headbanging, cutting or self-biting. This is a familiar one in an emergency department where you have people, particularly mental health patients, not always, I don't want to stereotype, but if they're left with no other perceived power to argue in the situation, they will hurt themselves to try and, assert their point. I've had lots of people try and hurt themselves and they end up often shackled, unfortunately, because they're going to be a danger to themselves. Obviously, there's need to improve that treatment without chemically sedating them or physically restraining them, but if they are going to hurt themselves or someone else, there's very little that you can do. Police, security, it's a bit scary. Property destruction, damaging property or belongings, either of their own, which is, no, they never do it, their own stuff. Everyone else's stuff normally gets broken. Examples include punching walls, breaking windows or throwing objects. Non-compliance, refusing to follow rules or instructions which can disrupt activities or routines. Withdrawal or isolation is also a form of aggression. Avoiding interaction with others, not participating in group activities or showing signs of social disengagement. Repetitive or obsessive actions seems strange to be included in a description of aggression, but it can be an act of aggression. Engaging in repetitive behaviours or focusing excessively on specific things. Antisocial behaviour it used to be called, now we're calling it inappropriate social behaviour. Acting in ways that are socially unacceptable or inappropriate for the context, such as undressing in public or using offensive language. And sexualised behaviour, non-consensual touch, sexually explicit language or exposing one's genitals in inappropriate. Yeah, that's aggression. Food related, this is an interesting one to me that this came up in the research. Food related behaviours can be an act of aggression. Binge eating or starvation. Or hoarding, or eating things that aren't actually food. So, everyone got a good understanding of aggression? Any questions? Confusion and cognitive impairment. Can you see, Chantel?
Yeah.
You can?
Yeah.
Confusion and cognitive impairment are behaviours of concern because they can significantly impact an individual's ability to function and interact with their environment. Confusion involves disruption in memory, thinking, focus and awareness, and it can manifest as disorientation, not knowing where you are or what time it is, memory disruptions, difficulty recalling recent events or familiar information, impaired thinking, trouble with tasks that require mental skills such as counting or problem solving. To differentiate confusion from cognitive impairment, confusion can sometimes be temporary. Cognitive impairment implies that it's a ongoing, debilitating, worsening situation. Cognitive impairment refers to a decline in cognitive abilities, including memory, attention, and problem-solving skills. It can cause behavioural changes, difficulty controlling emotions, and trouble communicating. So you may get someone who's got a cognitive impairment starting to be aggressive who wasn't before. Functional difficulties, problems with planning, organising, and executing tasks. Both confusion and cognitive impairment can be symptoms of underlying health conditions such as dementia, delirium, or brain injury. Yeah, what's the question now? I don't know. I think the question was, have you ever cared for someone with confusion or cognitive impairment? No, it didn't come up, sorry. Didn't come up? Let's skip it. Intoxication as behaviour of concern refers to a state. Does anyone know what intoxication is? No? No? A state where an individual's mental and physical abilities are impaired due to the consumption of a substance like alcohol and or drugs. Impairment can manifest in various ways, including slurred speech, impaired coordination, trouble walking or performing tasks that require fine motor skills, disorientation, confusion about time, place and identity, poor judgment, making risky or inappropriate decisions, and loss of inhibitions, engaging in behaviours that one might normally avoid. Intoxication is concerning because it can lead to accidents, injuries and other harmful consequences. It can also affect relationships, work performance and overall well-being. How should we respond to someone demonstrating a behaviour of concern? That's an open-ended question, you can type freely. Coming up. Respectful, validating, calm, listening with boundaries. Yeah, I like that one. Definitely ensuring safety for yourself and the person and the people around them. Is there any way that do we have a standardised tool to assess their behaviour? Sorry, were you guys finished? I just moved forward.
What are the
Just
options?
options 1, 2 and 3.
Right. I think it says yes, no, I don't know. So yes, no, I don't know.
Okay.
Shut up. Yes, we do. Everybody's correct. Why is it important to use a standardised tool to assess behaviours of concern? I love that cat. Did you guys have to do you have to do these at uni, like when you're in class? No? You never have to do Mentimeter or Cahoots or anything?
Oh, I do Cahoots like probably once a semester.
Really? They say to us that we need to do it every lesson. Interactive, getting people involved, stopping you from falling asleep. So I'm assuming that while you've been on the ward, you've seen the behaviours of concern assessment tool,
Yeah.
and it's part of the admission pack, is that right?
Yeah.
Have you ever had to fill it out? For anyone? Couple
Well, you
times?
do it on admission, so
Everyone gets a yes or no?
yeah,
Or
you do it on admission.
If there's any
And then-
changes that's
yeah.
there to remind you.
Okay.
On
There's any-
admission weekly, and I think that's every
Any
Wednesday,
changes,
and
yeah.
like PRN.
Absolutely. You guys are doing so well, thank you so much. So staff are aware and safety for both nurse and patients. Yep. To help everyone follow the same flow of de-escalation tools, perfect. Yes, I guess if there wasn't a standardised tool, one person may respond with a completely individualised approach that might be really effective, but then another person might respond with yelling and screaming and running down the hallway. It helps maintain respect and boundaries with the patient, while also predicting if any there will be any behavioural concerns during their stay. Yeah, very good. Where can I find more information? Just pretend I don't know anything, and just tell me where I would find more information on behaviours of concern and the tools that we use to assess. If you were explaining to someone that had no idea. On the ward, I mean, this ward.
Do you guys use everything on prompt?
It's difficult for you guys because you don't actually get access to prompt. It drives me mad.
So
That
Vinegar Health we do.
you do?
Yeah.
You
can
we
log
use
into
prompt.
the acute ward, log in and access prompt through that. Everyone can access acute ward.
Yay, they've got one
Yeah.
more day. Now we know. Thank you for that, Emma. So do that tomorrow, okay? Online prompt, yeah, prompt, BOC chart, nurse in charge, yeah, if all else fails, go to your nurse in charge. Or ask your friend, oi, where do we find more information? Where can we get support if we need it? Again, specific to this place. Sometimes, as a new grad, these are all the things you need to know. Where can I get more information? Who can I go to for more support? Don't you reckon? Who do I call? I find that really important.
Do we have I know some hospitals have helplines, for nurses? Like an EAP? Yeah.
Yeah,
I was going to say
Employee
that. I was trying to think of what it was called.
we every
They have to.
they do have to,
Okay.
and you do have
Yeah.
access to it whenever you like.
Yeah.
Yeah. Other stars, yeah.
I was like, what was it?
There. Katrina. Kelly, she'd love to hear about it. Kelly's the CEO, by the way. Yeah, I love it. You can always come to me, definitely. Who's responsible for responding to a person with a behaviour of concern? Is it always someone else? Everyone has a role. Love that.
Ding, ding, ding.
What are some red flags requiring, can never say that, further investigation? Example, acute head injury. If someone is walking in looking like that and behaving strangely, would that be a red flag? You can see it, can't you? You can see this guy's pretty banged up. some people who have had a stroke or have got really, really low blood sugar look drunk. Like really, people would walk past them on the street struggling and stumbling and think they're just drunk, but they may be having a stroke or hypoglycemia or a seizure or something. Don't always assume, or they may hit their head. Also, don't approach them if you're by yourself. Maintain your safety at all times. Yep, intoxication, acquired brain injury, dementia. So an altered level of consciousness could be from intoxication, could also be from a brain injury, acute or acquired, traumatic. Blood sugar is always really important to do if someone's behaving weirdly. We had a lady come in one night that was a stroke call, so that's all lights and sirens and urgent and all, and she was really behaving weird, like she was drunk. And she had a really low blood sugar. And we fixed it and then the stroke went away, amazingly. Yeah, gait, disorientation, intoxication or confusion. Confusion, sudden aggression, headache, vomiting, decreased GCS. Yeah, beautiful. So you probably can't see those, but I'll read them out if you like. So possible underlying causes of acute behavioural disturbance, so non-medical relationship conflict, anniversaries of past traumatic events, interactions with police and security, distress experienced by people with intellectual disability. Yeah, that can sometimes be the only cue that there's something the matter, is that their behaviour goes off. They can't tell you, I've got a really sore tummy, or no one gave me dinner, or something. Family violence, pre-hospital care, prolonged waiting times, that'll make most people cross. Distress from suicidal thoughts or bereavement. So medical causes of behavioural disturbance, head trauma, encephalitis, meningitis or infection, always something to consider. If someone is behaving really strangely, it could be cerebral irritation from an infection in here, and it causes swelling and all sorts of inflammation, and they get a look about them that's, you'll get to see like cerebral irritation look. They're agitated, they can't sit still, they're confused, probably with some other signs of high white cells and high CRP and maybe temperature, maybe a bit of stiff neck. Toxins, including prescription medication, metabolic derangement, hyponatremia can make people quite, especially old people that are on, the kidneys aren't so good at balancing all those electrolytes anymore, but also on lots of diuretics and stuff, they can get low sodium quite easily, and that can really make them go quite loopy. Hypoxia, thyroid disease, seizures or post-ictal, people can be quite confused, post-ictal. Pain, especially in people with intellectual disability or communication disorders or inability to articulate. So psychotic disorders, I'm reading it from the side. Mania, agitated, depression, anxiety disorders and personality disorders. Intoxication or withdrawal, alcohol can be a medical emergency. If they're in the throes of acute alcohol withdrawal, they can have seizures and die. Nicotine, I don't know. If you're withdrawing from nicotine and you've got a behavioural disturbance, you can give them a patch, but I don't reckon that's a good enough excuse, but it can cause people to be cranky. CNS stimulants, example, cocaine, amphetamines, like substances like meth, CNS depressants like GHB, benzos and opiates. Novel psychoactive substances like synthetic cannabinoids, I don't know, LSD and mushrooms are not novel. Oh yeah, they're in the next one. Hallucinogens and dissociative substances like LSD and mushrooms make people behaviour disturbances. No, I can't even read that. But that's your management matrix. Is that the same as what's on the forms? Yeah.
Yeah.
Yep. Management matrix will determine response required. So you identify the underlying issue, Identify triggers that may escalate, decrease exposure to triggers, maintain positive interaction, communicate and document all observations and interactions, interventions, early referral, so early escalation to medical. If anyone's got a behavioural disturbance, it could be particularly concerning. It may not be medical, but it might be. And call a code grey. What happens if you call a code grey here? Have you ever called one?
We don't really call code greys here.
What do we do?
We have the duress alarm, which contacts our security system, who will then call us and
Say, are you okay?
determine whether it actually is an emergency. So we don't really use it. We just call the cops.
Yeah, right. Do you call triple O or non-urgent Kerrang?
Triple O, I think.
And say, I'm so and so from Kerrang Urgent Care Centre. I've got a
Yeah,
patient here that's and do they attend usually?
I think so.
Good.
I've never had to.
I've had to do it several times, and they're usually pretty.
Not here. I've had to call code greys before, but
Yeah.
I've never had to call the police here. There's a few names that
They're
are
known
on
to
the
police.
handover sheet. Yeah. So if they even turn up at the door, we're not allowed to let them in without calling.
Absolutely. Yeah. Don't make exceptions if it's written down and they're not meant to. Don't make exceptions.
A lot of them are drug seeking and stuff.
So, what are some strategies for de-escalation? Have you done any training on that at uni? No. What about you guys?
No, at uni.
Not really at uni. What about here? The education department needs to step up, don't they?
I reckon I have.
You probably should.
Yeah, we should, shouldn't we?
We should. Look, that's good. That's a gap analysis to identify a knowledge deficit. We need to talk about de-escalation. Behaviours of concern, de-escalation, and procedure for calling for help. So, whatever you think off the top of your head, there's no wrong answers. Active listening, validate feelings. Yep. There are some techniques. It's called low and slow. Low tone voice, slow speaking.
I didn't mean to put the I in. That was an accident.
I understand. Validate feelings. I empathise. Give them space. Don't ever block an exit. Don't stand in an exit. You know, they will come for you. And they'll feel really trapped. So it's important to make sure that they can, if they're not allowed out the exit, then just shut the door and don't stand in front of it. But always keep yourself safe.
And the last thing you want to do is trap yourself into like a bathroom
Absolutely.
where
Don't
they're
go
blocking
into
the
corner.
door or in a corner or something, yeah.
Stay outside if you can. Don't go in. Definitely don't go in by yourself. If in doubt, don't engage. Just get yourself safe and call for support. Is it ever okay to treat people without their consent? Yes, no, I'm not sure.
Depends on the situation.
Yeah.
It's not really like just yes or no. It's a bit like, yeah, it depends on the situation.
Yeah.
If they're mentally
So
able, like cognitively, like if they're aware of their decisions, and then you could argue mental health as well. People are put on hold against their will.
So that has a definite process of identifying.
Yeah, it goes to like
this
the tribunal and stuff.
Or they can be put on a community order or a section or a
Yeah.
24-hour hold or somewhere it's called an order, an assessment order.
Yeah.
Where essentially they've been deemed not capable of making sensible decisions, and they've put themselves and others
at risk to themselves or anybody else.
And in that case, you still have to justify your what you've done and your interventions and the level of force, etc., and document it all really clearly. And the use of the least amount of force and the least amount of chemicals, etc. I've certainly had to give a lot of midazolam injections or droperidol injections through people's jeans while they're being held down by police and things. It's not ideal, but sometimes it's the only thing you can do to keep the person safe and the other people safe. Otherwise, they may be threatening to run out in front of cars and running around with weapons and so. So this is just my disclaimer. If the situation is too dangerous for the clinical team to intervene and or police are required to disarm and restrain the patient, we've already established that. You're never going to get in trouble for calling the police. Like, if they go, we probably don't need to be here, is everyone okay? There's no like, well, you shouldn't call police. That doesn't happen. If you want to call police, call police. We've already answered that.
Mhm.
Very good. Thank you, everybody. For the purposes of the video, there will be an evaluation form that you'll all fill in. And there is one more session, if that's okay. I'm going to start at video again. This one hopefully will be